Okay, now let's come to the coverings of the heart. So, when you open up the chest cavity, so of course the sternum is there, the breastbone, you cut this breastbone. So, whenever they're doing a open heart surgery, they have to cut the sternal bone. Okay, and the ribs have to be stretched out. And then you're going to see the heart in the mediastinum. All of you know this. So, the two lungs. As soon as you open up, you're not going to see the heart itself. You're going to see a thick layer, a connective tissue that covers the outside of the heart. Now, this is called the fibrous pericardium. Fibrous pericardium. It's a thick, fibrous connective tissue that protects the heart. And it on the lower portion, it is actually attached to the diaphragm. Okay. Now, once you remove the fibrous pericardium, what is underneath the fibrous pericardium, there is another layer of protection. This is called the serous pericardium. Okay, this is called the serous pericardium. So fibrous pericardium is the one that's outside, and underneath the fibrous pericardium is a thinner layer, which is called the serous pericardium. Serous means wet membrane. You have all learned about membranes in Bio 141. Plural membrane, serous, pericardial membrane, peritoneal membrane. So serous membranes are wet membranes, moist. What is the purpose of it? They allow a structure to contract and relax without any friction, without any rubbing against each other. Smooth contraction and relaxation. So you have the serous pericardium. Now the serous pericardium itself has two layers. Okay, it's like a double layered membrane. So you can see this blue. You see that blue color? That's the serous pericardium, but it is divided into two. One layer that is covering the outside of the heart. It is stuck to the heart. That is called the visceral pericardium. The outer layer, which is stuck to the fibrous pericardium, is called the parietal pericardium. Okay, so always remember, parietal means outside, visceral means viscera means organ. So visceral means attached to the, stuck to the organ. So the serous pericardium, you can consider the serous pericardium. So fibrous pericardium is, let's say you have you have been invited to a party, you have to carry a dish. Okay, so you made something in a casserole, and then you cover it with a cling wrap. The cling wrap is the serous pericardium, because it completely sort of blends with your with the utensil or the bowl that you're carrying. It nicely wraps it up. So the serous pericardium is like a cling wrap. And then on top of it, because you don't want the dish to be seen outside when you're carrying it, you put an aluminum foil on it, which is a much more thicker, and it is it's opaque kind of a covering. So the fibrous pericardium is like the aluminum foil that you put on top of it. So fibrous pericardium is thick, serous is clingy, like a cling wrap, and in the serous pericardium, you have two layers, parietal and visceral. Parietal means outside, which is just underneath the fibrous pericardium. And then the second layer is a cling wrap that clings to the outside of the heart. That is called the visceral pericardium. And another name for visceral pericardium is epicardium. So after this session, you should not forget what is parietal, what is visceral. Okay, parietal is always the outer membrane. The inner membrane which clings to the organ is called the visceral. In the case of the heart, the visceral pericardium is named epicardium. Okay, that's all. It's called epicardium. Now, under the epicardium, so you can see that the epicardium is stuck to the outside of the heart, that blue layer. What is inside that? The middle layer, this thing that you're seeing here, this is called the myocardium because it is made up of cardiac muscle. This is the myocardium. Okay. Now, the innermost layer, the layer that is in contact with the blood. You see this one? This innermost layer. Okay. And right here, it's the same thing here. This is on the right ventricle. This innermost layer is called endocardium. Endocardium. So, pericardium is connective tissue. Myocardium is cardiac muscle. Tissue-wise, what is the tissue, right? So, pericardium is connective tissue. Myocardium is cardiac muscle. Endocardium is epithelial tissue. Epithelial tissue. Simple squamous epithelium. Okay? Simple squamous epithelium. Single layer of flat cells. Okay? So the blood is in contact with this endocardium. Okay? So that's what I told you. Fibrous is dense, irregular connective tissue, and the serous pericardium is a very thin, delicate membrane. Okay. Now, why should we know? So this pericardium, the purpose, of course, is protection, and it also helps to keep the heart in place. Okay. Now, why should you know about the pericardium? The reason is because infections can occur. Viruses can infect the pericardium. Bacterial infections, fungal infections, you name it. It can cause infection and swelling of the pericardium. We call it pericarditis. Itis means, the word itis means inflammation. So whenever you see that at the end of a word, that means it is inflammation. And the more of course, pericarditis, if it is bacterial pericarditis, obviously it will cause problems with the functioning of the heart. But depending on the age of the person, you can give antibiotics, you can treat it. But the most serious problem is sometimes because of the infection, fluid will collect. So fluid will collect between the fibrous pericardium and the serous pericardium, or fluid will collect between the parietal and the visceral pericardium. And once fluid collects, the heart is not able to expand and contract normally. So this can be a big problem. Pericardial effusion can be a big problem. It's usually an emergency situation where they may have to put a needle in and take out all the blood. Take out all the fluid, the infected fluid. And occasionally what can happen, especially in stab wounds, if somebody has a stab wound to the chest, sometimes the knife will penetrate the fibrous pericardium and it'll penetrate the serous pericardium as well, and blood will start collecting between the heart and the pericardial layer. So blood will start collecting there, and that is a serious condition. It's called cardiac tamponade. That means the heart will stop beating. So it's essentially very difficult. It has to be treated on an emergency basis. If the person is still alive, it has to be treated very, very quickly. Okay, otherwise you can lose the patient. So that's why a knowledge of the pericardium is essential. Okay, so whenever you see a patient who has some irregular heartbeat, fever, and having difficulty, this is one thing that you have to think of as well. Okay, So I've already told you about this. The outermost layer is called the epicardium, which is nothing but the serous pericardium. Middle layer is myocardium. And obviously, do remember that there'll always be some fat that covers the heart. So those of you who did a little bit of sheep dissection, heart dissection, you saw the yellow fatty tissue. So there is always fat as a protective layer for all the organs. So that's what this yellow that you're seeing here is the fat. So, and then myocardium is a cardiac muscle, and then endocardium is the innermost simple squamous epithelium. Okay. Now, I told you about the pericardium getting inflamed, pericarditis. You can also have this. This cardiac muscle can get infected and inflamed. That is called myocarditis. Endocardium can also get inflamed. It's called endocarditis. Okay. So during COVID, when it first started, when the pandemic started, many individuals, they had lung infection, pneumonia, and many of them also died because of COVID myocarditis. Okay, it can affect, many of them died because of myocarditis because it causes inflammation of the cardiac muscle. And once the muscle is damaged, the heart is not able to pump. So people died because of myocarditis as a complication of the viral infection. So viruses can cause inflammation of these layers. Bacteria can cause inflammation. So lots and lots. Okay. So I hope that you're able to see the significance, okay, of this. Now, let's move on. Uh, in a normal heart, I already told you left ventricle is a larger chamber than the right. So look at the right ventricle. So you'll be able to see this actually. See the left ventricle, more circular structure. More circular structure, left ventricle. Right ventricle is more like a crescent. Again, the left ventricle, the wall of the left ventricle, if you can see, very thick cardiac muscle. Interventricular septum also very thick because the left ventricle has to generate a high pressure to pump blood. Right ventricle, you can see the wall, cardiac muscle is very thin because all it needs to do is pump blood to the lungs. Okay, so this is how the normal heart structure is. Now the valves, this is what I told you. See how the valves open and how they close. Okay, so these are the bicuspid and the tricuspid valves. So this is showing you the bicuspid valve here. Open position. See how the valve opens downwards like that. The leaflets open downwards. Okay, and then blood flows from atria to ventricles only in one direction. And once the valves are closed, once the valve is closed, it will not allow blood to flow backwards. Okay. Now, that is the function. What is the function of these papillary muscles and the chordae tendineae? So these are the chordae tendineae. These ligament-like structures that you see, these are the chordae tendineae. So the purpose of the papillary muscle and the chordae tendineae is to keep the valve tightly closed. So when the papillary muscle contracts, the chordae tendineae are stretched tight and they close the bicuspid or the tricuspid valve tightly so that blood cannot flow back into the atrium. When the papillary muscle is relaxed, the chordae tendineae are loose, the valve opens, and blood flows from the atria into the ventricles. Okay, so this is an important, uh, piece of info that you should know. Okay, so where are the papillary muscles and the chordae tendineae found? They are only found in the AV valves. Okay, not for the semilunar valves, only for the AV valves. And these are necessary, papillary muscle and chordae tendineae are necessary to keep the valve tightly closed. When do you want it tightly closed? When the ventricle is contracting. When ventricle is contracting to pump the blood out of the heart, that's when you want this AV valve to be tightly closed so that blood doesn't flow back into the atrium. Okay. Now, the reason why you should know this is because sometimes, because of a heart attack, if an individual has a heart attack that damages the chordae tendineae, okay, suppose they have a heart attack, blood flow to the heart is decreased, cardiac muscle, and then the chordae tendineae also get affected. If the chordae tendineae break or get affected, the valve will not close properly. Okay, and when it doesn't close properly, blood will backflow into the atrium whenever the ventricle contracts. Okay, it'll backflow into the atrium. So, if you think about it, it's not a very difficult thing to understand. Okay, so these are the AV valves. Normally, they should close like that, and then when the ventricles contract, right ventricle pumps the blood into the pulmonary trunk, left ventricle will pump the blood into the aorta. So you don't want the blood to go back into the atria. That's why these valves have to be tightly closed. And that is what the papillary muscle and the chordae tendineae do. But if they are not functioning properly, the chordae tendineae is broken, or if the papillary muscle is damaged, then this valve will not close properly. These won't close. Okay, so you're going to see if this doesn't close properly, let's say this one, then it is going to cause backflow of blood. Whenever the right ventricle contracts, the blood will flow backwards. Some of it will go into the atria, some will go into the pulmonary trunk. So that is what can happen. Okay, the importance of chordae tendineae and the papillary muscles. Okay, so this is how the valves look like. Okay, so the semilunar valves and the atrioventricular valves. Basically, these are fibrous tissue. Okay, there's a fibrous ring, and then the valves are actually thick fibrous tissue. Now, just a point of interest, nowadays you can, if somebody has a weak valve or a valve that is not functioning properly, you can do valve transplant also. Okay, you can do a valve transplant. You can use valves from pigs. Pig valve can be used. So they do transplants as well. Okay, so valve transplant is possible. Or if the valve is not closing properly, you can tighten the valve also. You can stitch it up and tighten it a little bit if it is very loose. So cardiovascular surgery has advanced quite a bit. Okay, so if you look, one of the places where most of these advanced kind of things are done is the Cleveland Heart Clinic. Okay, that's where a lot of these things are done. Of course, many other places as well, but I'm just saying that's one of the premier institutions where a lot of cardiology work gets done. Okay, so now coming to heart valve disorders. Okay, why once we have studied about the normal heart valves, what are the disorders that are possible? There are two things that are possible. Whenever you talk about a valve, there are two things. One, maybe it is too tight and doesn't open properly, or the valve is too loose and it doesn't close properly. Those are the two things. Narrowing of the valve is called stenosis. Stenosis. A loose or a lax valve is called incompetency. Incompetence. Incompetent valve. Okay, a valve that does not close completely, and a valve that is extremely narrow and restricts the blood flow is called stenosis or incompetence. And whenever there is a valve disorder, whether it is a stenosis or an incompetence, it will result in, whenever blood is being pumped, blood is entering the heart, or blood is being pumped away from the heart, you will hear abnormal heart sounds. Okay, whenever the valve is abnormal. Okay, So whether it is a stenosis or an incompetence, it will lead to abnormal heart sounds, which are called murmurs. And I'm sure all of you have heard about this. Some of you probably do have an issue also with it. So, heart murmurs. Depending on which valve is having the issue, the murmur will be heard in specific periods of the heartbeat. Okay, so you can have mitral valve stenosis, tricuspid valve stenosis, pulmonary valve stenosis, aortic valve stenosis. Okay, so stenosis 4. Incompetence, same thing. Mitral incompetence, tricuspid incompetence, pulmonary valve incompetence, aortic valve incompetence. All four for both of them. Okay. Now, coronary circulation, the importance of the coronary circulation. Again, we have talked about this. Why should the heart have its own special circulation? Because the heart needs oxygen and nutrients. It is the most active organ in your body. Okay. Other than the brain, the heart is the most active organ. Okay. Heart, kidneys, brain, these are very active all the time. So it requires a lot of oxygen. Okay. So it has its own special blood flow supply. Okay. And when does the heart receive blood flow? When the heart is relaxing, not when the heart is contracting. When the heart is relaxing, blood flows through the coronary blood vessels. Okay. Now, you have learned about the coronary blood vessels. Okay. Right coronary artery, left coronary artery. And then let me see if we have a picture of that now. Okay. Now, why are we so concerned about the coronary circulation? This is because if any of the coronary blood vessels get blocked, then blood flow to the heart is compromised and the cardiac muscle can die. Okay? Death of the cardiac muscle. If blood flow to the heart muscle is completely stopped, heart muscle can die. And the problem with the cardiac muscle is that it doesn't regenerate. Okay? There are no stem cells that can make new cardiac muscle. Once a particular portion of the heart muscle dies, it is dead for all purposes. It's not going to function well. Okay. Now, this is one of the most commonest problems that we see in the world. Okay. So, whenever there is a narrowing of the blood vessel, it doesn't have to be a complete block. Even if it is a narrowing of the blood vessel, blood flow to the heart is compromised. Okay. Now, what is it that causes this narrowing? Generally, it is due to deposition of fat on the inner wall of the blood vessel. So, in the wall of the inside wall, there is a deposition of fat. Okay, and sometimes calcium also gets deposited, and this will steadily. It'll start as a small structure, and then it'll progressively become bigger and bigger and then start obstructing the blood vessel. Okay. We call this condition atherosclerosis. Atherosclerosis, that is hardening of the blood vessels because of the hardening of the arteries, because of deposition of fat or any other reason. Okay. Now, what are the risk factors for developing this atherosclerosis? The risk factors are quite a lot. Okay. High cholesterol levels in blood, high blood pressure, cigarette smoking, alcoholism, obesity, lack of exercise, people who are diabetic, or those who have a genetic predisposition. If their parents have had a heart attack, their grandparents have had a heart attack, the male gender, All of this, lots of different, and you all know about this. You all know about the risk factors that can lead to heart issues. Okay. Now, when the coronary blood vessel is just narrowed and blood flow to the heart is reduced, you call it myocardial ischemia. Ischemia means decreased blood flow or decreased oxygen supply. Okay. So, when a person has myocardial ischemia, when there is less blood flowing to the heart, the symptoms will be they will feel breathless when they climb up the stairs or do exercise, or they may feel a mild heaviness in the chest when they are carrying something or running or jogging. Day to day activities, whenever they are stressing themselves, they will find that they have a chest pain or they have difficulty in breathing and they will have to rest before they can continue doing something. That is myocardial ischemia. If this gets worse, if it is not checked, and if it gets worse, then the blood flow to the heart gets completely blocked and the heart muscle dies. Okay? Complete obstruction. This is called myocardial infarction. Myocardial infarction is what we commonly know as heart attack. This is what is a heart attack. Okay, so here the cardiac muscle cells get completely damaged, and you can do a lot of tests, blood tests, to find out. Okay, when the muscle dies, you have heard of muscle proteins: actin, myosin, troponin, tropomyosin. So when heart attack occurs, some of the enzymes will there are certain enzymes that are released by these cardiac muscles: troponin T, troponin I. So they measure all this. They measure all these things, and then you know confirm that it's a heart attack. If it is a heart attack, then what is it that you can do? Can you help a person who comes to the ER with complaints of chest pain and difficulty in breathing? And then you do all these tests and you see that the person is having a blocked blood vessel. And so you have to treat it. So, treatment can be, of course, in early stages, you can use medications. But once there is an obstruction, then there are two things that can be done. One is called using a stent. Okay, so many of you might have heard of this. So, if this is the blood vessel here is blocked because of the atherosclerotic plaque, you can put a wire mesh here and then you can open it up. Okay, you can open this narrow part up by putting a wire mesh and making sure that the blood vessel is open all the time. That is called a stent. Okay, so you can put a stent in one blood vessel, two or three coronary blood vessels. Suppose stent doesn't work for a person, then you do what is called a bypass graft. Okay, bypass, or what we call as, in clinical setting, you would have heard, if any of you are working in the hospital, you'll hear CABG, CABG, coronary artery bypass graft. So what you're doing is you're going to take a blood vessel from another region of the body, and then you make a graft like that. You make an alternative route. So you stitch one end of the blood vessel to the aorta, stitch the other end to the blood vessel beyond the block. So the block is here. So you stitch it beyond the block. So now the blood will bypass that obstruction and it will go to the heart. Okay. So coronary artery bypass graft is very commonly done these days. Okay. To help people who have blocked coronary blood vessels. And, it works well. So you can do a single blood vessel um, graft, you can do double, or triple or quadruple, depending on how many blocks are there, you can do it. Okay, and of course you take into account the patient age and health and everything. So bypasses, and all of you must have heard about this. So now you know what a bypass means. Okay, bypass simply means taking a blood vessel and then using it to form an alternative pathway. Now, what are the blood vessels that are normally used for this? Okay, we use the saphenous vein. I'm not going to tell you where the saphenous vein is. This is one of the longest veins in the leg, superficial vein. So, saphenous vein is a small piece of the saphenous vein is taken for the graft. Or the second one that can be sort of sacrificed for this is the internal mammary artery. Internal mammary artery. Artery. So either the saphenous vein or the internal mammary artery is generally used for making this graft. Okay. So you just cut a small piece and cut a piece the right length, and then you attach it. Okay.
A quick
So
question.
yes, please.
Um, I was reading a little bit ahead about the blood vessels to the brain and saw something called the Circle of Willis, I believe it was, that
Yes,
is
yes.
like a redundant blood supply in case one part of the blood supply to the brain is broken. There's nothing like that for the heart, no redundancies in the coronary arteries.
Yeah, good question. Yeah, there are no redundant blood vessels, but what happens in some cases is, as the obstruction, suppose they have an obstruction in one of the blood vessels, the heart compensates because they are living with that and they are still continuing. The heart compensates by what is called angiogenesis, and this is possible in everyone. Angiogenesis means formation of new blood vessels. Okay, so new blood vessels can form. So let's say you have always been a skinny person, and all of a sudden, the something goes wrong. You're tending to put on weight, and your weight starts to increase. So as more tissues form, as more adipose tissue forms, of course you need blood supply to these tissues. So new blood vessels form. So angiogenesis is a very common phenomenon that happens in order to, whenever the tissue size increases, new blood vessels form to supply blood. So you also see angiogenesis in the heart. So sometimes in people, when they do a routine test and they see that some of the blood vessels are blocked, they will also see that to compensate for the block, there are new blood vessels that have already formed to supply blood to the region that is not getting adequate blood. So they see adequate angiogenesis. So if they see that, then they sometimes delay the process of a stent or a bypass graft, because but that again, um, uh, it is very, what should I say? It's very individualistic. Not everybody responds the same way, but this is one of the properties of any organ or the body, to be able to form new blood vessels. Did I answer the question? Did that make sense, Meredith?
Yes, thank you.
Yeah, so there is no redundant blood vessels like in the brain. Yes, the circle of Willis, you have two basic basilar blood vessels, and you have the what is that, vertebral arteries. So all of them, if one gets blocked, there is always another one that can supply blood to the brain, but not like that in the not like that in the heart. Okay, but new blood vessels can form. Right. And one other point of interest that I just wanted to talk to you about before we move on to the next one is this blood vessel. Okay. So this is the left coronary artery. This is the right coronary artery, this one on the right side. The left coronary artery divides into this branch, the one that is going down like this. This is called the anterior interventricular branch because it is between the two ventricles. It's called anterior interventricular branch. And this one that is going towards the back, this is called the circumflex branch. Okay, so we've studied this in the lab. Now, the anterior interventricular branch, the interesting thing about this supplies almost 90% of the anterior portion of the ventricle. Okay, this anterior interventricular branch, very important blood vessels. In the clinical setting, again, see, sometimes physicians use very different terms. Anatomically, we say anterior interventricular branch. Anterior because it's in front, interventricular because it's between the ventricles. But the physicians will use the word left anterior descending artery because it's going down. Left anterior descending artery, or LAD. This is what they will use. So they'll say block in the LAD. Okay, they don't say block in the anterior interventricular artery. The LAD blocks, 70% block in LAD or 90% block in the LAD. So it's good to know the alternate term as well. Left anterior descending is the same as anterior interventricular artery. So majority of the heart attacks, this is because it supplies most of the blood, most of the ventricle, left and the right. You have heard, I'm sure all of you must have heard about some person or the other in your family, or maybe someone known to you, dying suddenly. You know, they were fine the previous day, the next day, all of a sudden they drop dead. Okay, you hear they are dead. Most often it is because of a massive heart attack. Okay, massive heart attack. And majority of the time, the culprit is an obstruction in the LAD, anterior interventricular artery. This is where the obstruction is. Because once this blood vessel gets obstructed, most of the ventricle, most of the heart will not receive any blood flow. And if it is a massive obstruction, complete stoppage of blood, the person will just drop dead. Okay, you hear about people just dropping dead. You know, they go to the office and then they are fine, and then all of a sudden they are no more that same evening. So those are massive heart attacks where it is this is the culprit. The left anterior descending is the culprit. So in ancient days, they used to call this this artery was named the widowmaker artery. Okay, because people used to die and lose their spouse, so widowmaker. Okay, so that's about the left anterior descending artery. So, you know, very interesting. Cardiology is quite interesting if you look at it, and there's so much of advances that have come up, you know, unimaginable advances, even since the time I was a student. Now things have changed so much. Cardiac muscle. I just want to remind you about the cardiac muscle structure. You've all learned this. Who's coming in at this time? Diana. Oh my God. We're going to finish now. Okay. So, the cardiac muscle, as you all know, it is a striated muscle. And the only difference between skeletal and cardiac is that in skeletal muscle, the fibers are individual fibers. They are not linked to each other. Whereas in the cardiac muscle, these are interlinked fibers. They are branched and interconnected. So all the fibers are connected to one another. And the connecting point is a gap junction, which is called the intercalated discs. Okay, these are the, oops. So these are the intercalated discs that connect the individual fibers. And the cardiac muscle fibers have a central nucleus. So the entire atria is one muscle sheet, cardiac muscle sheet. The entire ventricle is one muscle sheet. Okay, so they are all linked together. So the functional significance, why should it be a single, why is cardiac muscle like this? Because you cannot have one muscle fiber contracting and the other one not contracting. If you want a pump to be effective, the entire cardiac muscle has to contract at the same time. So that's why all fibers are linked. So what it means is when action potential arrives at one fiber, it'll immediately get transmitted to the next fiber and the next fiber, all in the same time, very quickly, so that the entire heart will contract and relax as a single unit. Okay, and that would make it an efficient pump. So that is the reason why the structure of the cardiac muscle is different from the skeletal. It is interconnected, it is branched, and the entire cardiac muscle functions as one single unit. And we call this the functional syncytium. Syncytium means sheet of muscle, a single sheet. Okay, instead of individual muscle fibers, it's a single sheet of muscle. Okay, so now this in the cardiac muscle, if you look at it, so cardiac muscle, there are two types of muscle fibers that you can see. One is what is called the contractile cells or the working cells. Now, these contractile cells are found in the wall of the ventricle and the wall of the atria. So the muscle that makes up the wall of the chambers is called the contractile cells or working cells. Okay. But in addition to that, within the wall, you have specialized cells. These are also cardiac muscle cells, but these are specialized. Okay. You won't be able to make out much of a difference between the cardiac muscle fibers, but their function is very specific. These are called the conducting cells. So you have the contractile cells which form the actual wall of the heart, and they are the ones that are going to contract and relax. And then you have another specialized structure within the cardiac muscle, which is called conducting cells. Now, these conducting cells, the feature of the conducting cells is that they are capable of producing their own action potentials. So you don't need a nerve to come and stimulate the heart. The heart can produce its own action potentials. Okay. Look at here I just want to differentiate skeletal muscle. A skeletal muscle will not contract unless and until an action potential arrives from the nerve, goes through the neuromuscular junction, and then the action potential has to come from the motor nerve, and then it has to activate the skeletal muscle. In the case of the heart, you don't need a nerve to come and stimulate the heart to contract. The heart has its inbuilt cells which can make their own action potential. Okay, so the heart has an inbuilt, like a electrical signal generator. Okay, you can think about it as a inbuilt battery that can produce the electrical signals. So that is what is a significant feature of the heart. So if I were to take out the heart, even from an experimental animal, let's say I'm doing a experiment on a frog heart or a rabbit heart, I can cut off the heart, put it in a lab lab setup, make sure that the heart is getting enough nutrients and oxygen. The heart will continue to beat until I perform whatever experiment I want to. Okay, because it doesn't need a nerve to influence the beating of the heart. That is one of the reasons why heart transplants are also possible. So you could have a person on the West Coast who is brain dead, and the family wants to donate the organs. The heart can be separated out, and it can be kept in a, ice, in a special box with ice and everything, and it can be airlifted to the east coast to be transplanted into a patient who requires a heart. Okay, so this is because the heart has the inherent capacity to produce its own action potentials and be able to beat. Okay, nerves are only going to either increase the heart rate or decrease the heart rate. They are not necessary to start the heart to beat. Okay, so I hope you understood that. We will be talking a little bit about this when we talk about ECG. So we will do that. Okay, so two types of cells: working cells, which are the wall of the heart, they actually contract and relax. And then the conducting cells are the specialized cells which produce an action potential. Okay, so let's stop at this. The time is exactly 2:05. We will start at 2:30. Okay, we'll start at 2:30. So take a 25-minute break. The lab section will start at 2:30. Okay, and then if you have questions, I'll answer the questions at that time as well.